Okay.
Humphrey, can we record it? Okay.
Mambo,
Okay. Good
everybody.
evening.
Go ahead.
Okay, welcome, baby. You can start. Just start.
Go ahead, Dr. Emmanuel.
Okay. Good evening. So welcome. We today have a DCR session on which Professor Helen Weber will take us through the cultural inference, and yeah, we can start, and then later we'll have some questions and discussion.
Okay,
So,
great.
Prof, please welcome. We have resident here too, and we have to be like 46 of them, but I expect to be more than 30.
Okay, great. Lovely. Can I just
Okay.
ask everybody for 1 second to let me see if I can figure out how to see it, how to see you all. Maybe I'll do it at the end. Just to remove your video for a minute at the end, but we'll get started because you're all here on time, which is lovely. And I'm going to begin. So I'm Ellen Weber, otherwise known as BB. I am an emergency physician at the University of California, and we're here to talk about something called causal inference. And what this is really kind of more an underlying idea about research. Then it's not necessarily something you're going to then take this now and put this in your methods, but it's something that you have to have in your knowledge base so that you use the right words and you have the right conceptual framework for the research that you do. In fact, for the research everybody does. So, what is causal inference? So, there are a lot of definitions on the web and in books, and they all sound very intimidating. Here are three I found just quickly last night. Causal inference refers to the design and analysis of data for uncovering causal relationships between treatment intervention variables and outcome variables. Causal inference is the process of determining whether one variable causes a change in another variable. Or causal inference is the process of identifying and quantifying the causal effect on one variable on the other. Basically, the question is, does A cause B? And that's all that we're talking about here. But there's some nuances depending on the kind of research study you do as to whether you can say A causes B. Now, causation is not the same as association. Association means that a change in one variable is associated with a quantifiable change in another variable, usually to the same extent. But we don't know which if one causes the other. For example, many people in prior studies at Mmbando have found that when they've looked at risk factors for death in patients who have sepsis or respiratory failure or whatever, they find that patients who are intubated are more likely to die. Well, that's an association, but it's not likely that it's a cause and effect, right? Intubation is not likely to cause death. I mean, in some people's hands, maybe, but for the most part, we do intubation in order to prevent death. So it's an association, but it's not necessarily a cause and effect. Now, another term that's frequently used is correlation, and it's frequently used the wrong way. So I wanted to clarify what that is as well. Correlation is a specific type of association in which the changes occur in a linear fashion. So for every change in A, every increase in A, B increases. Every two increases in A, B increases twice. It's just really a statistical formulation of a certain kind of association. But again, it is not doesn't tell us whether the two things whether one causes the other. And here's just kind of an example of what you can see. You see, with associated, they can go in kind of either direction and in any which way. Whereas not associated, there's just no connection between variable A and variable B. If they're positively correlated, everything moves up together. A and B move up together. If they're negatively correlated, when A goes down, B goes down. So again, association is more of a general term, and when you use the term correlation in a paper, you really should have been doing a statistical test that usually has a correlation coefficient. And associations we often think about with regard to hazard ratios or odds ratios and things like that. But the main thing about all of these things is they don't tell you if one thing caused the other. They just say that the two things occur together. In fact, when we have associations or correlations, we could have it could be go in any direction, one of three ways. It could be the one variable is the cause and the other is the effect. So A causes B, or the effect could be the cause. So B causes A. Okay, just like or there could be a third factor that affects both of them. And here's a couple, we'll go through some examples so you can understand the concepts here, because you just can't take at face value that when two things are associated, that one causes the other. So we're going to look at three possible findings from studies. One is we do a study and we find that older patients are more likely to die from sepsis. And two, we do a study and we find that patients who are intubated are more likely to die from sepsis. That was the example I mentioned earlier. Or a third example might be people who are poor have less education. Okay, and we're going to show you how they could be more than one of these options of cause and effect. So older people are more likely to die from sepsis. First question is, can older age be a cause of increased mortality and sepsis? In other words, does older age cause death? And the answer is yes. We know that older people are more likely to die, and it is probably because of their age. Does it work the other way? Can mortality and sepsis, sorry, can it should be can older age be caused by sepsis? And that's not true. I wrote this wrong. Okay. In other words, does mortality cause older age? No, that's not possible, right? But the other possibility is that there's a third factor that explains why older people are more likely to die from sepsis. Is that possible? Yes. For example, um, oh, um, sorry. Oh yeah. Okay. If people who are older also have more comorbidities. So it may be that it's not the older age that's causing them to die from sepsis. It's the fact that they have more comorbidities. And so if you took your patient sample and you divided it further, not just by age, but by comorbidity and age, you might find that the people who are older and have comorbidities are more likely to die than younger people, but that people who are healthy and older have the same risk of death as younger people. So in that case, there's a third factor that's affecting that relationship. I'm going to talk about that in a minute. But I hope that's clear that there's a third way to think about that. Another example, we talked about this earlier. Could intubation, patients with sepsis who are intubated are more likely to die? Could intubation cause the result? Could intubation result in a greater risk of death? In other words, does intubation cause death? Well, we hope it doesn't. We don't think it does. Okay, so this is not likely to be a cause and effect association, but we see it, right? We see it in the study. Okay. Could death be a cause of intubation? Of course not. You can't. You can't die to cause intubation. That makes no sense. Okay. But could there be a third factor that explains why older people are more likely to, no, sorry, I wrote this wrong. The third factor that older people, that intubation can cause death. And there is. All right. We have another factor in there, which is who gets intubated. Sick people get intubated. So what we know is that if you're sick enough to get intubated, you're more likely to also more likely to die despite being intubated. So that's another third factor that's affecting that association. And so it's not a true cause and effect. Okay, and here's a third option. Okay, just I'm trying, I know it's kind of me blowing your mind a little bit, but I just want you to see how you just can't take this all at face value. Could people, we know that people who are poor, say, are less healthy. Okay, could poverty cause worse health? Yes. People who are poor, they can't get medical care, they can't get medications, they don't have transportation, they don't see a doctor, and so forth. Could poor health result in poverty? So this is a potential where the effect is, and the outcome, the poor health, is actually the effect, and poverty is actually the cause, and poverty is actually the effect. And that can occur, right? If you're poor in poor health, you can't work. And so you might be poor. And is there a third factor that could explain why there is an association between ill health and poverty? And there might be. And one of them might be, for example, education. The people who are have who are poor may not be as well educated as people who are have more money, and people who are not as well educated may not see a doctor as much, may not know when they have symptoms that they have to worry about, may be just too busy trying to work to take care of their healths, live in less desirable areas. So there can be this third act factor. And that's why this concept of causal inference is so important, because we just can't take for face value that A causes B. Now, we'd like to know why A causes B, and that is sort of what's behind all of the research that we do, because if we can determine that A causes B in terms of a disease, then we can treat the disease because we know what's causing it, and we can prevent the disease. Think about, we know once we've figured out that malaria came from mosquito bites, we could put up nets to prevent malaria. When we figured out that smoking cigarettes causes cancer, we told people not to smoke. They don't want to listen, but we told them that. So we can prevent the disease as well as treat it once we know what causes it. Similarly, we can do the same thing about treatments. We need to know if we give this antibiotic, does it actually treat this disease? What if we give 3 antibiotics? Which one of those actually treats disease? We don't want to keep giving 3 antibiotics. We want to give one, and we want to know that that's the one that's working. And do vaccines work, right? We want to know that giving a vaccine actually prevents a disease, and it's not some other factor around giving that vaccine. Perhaps that the person comes to a vaccine clinic and they get some education about preventing the disease, and that's all that is actually working. And we shouldn't be spending money on vaccines. So we need to hone down as to what actually is the cause and what is the effect. And that is all of what we're trying to do in research. We're trying to figure out what causes what. Now, if you remember back to I think it was our very first, the talk that Dr. Humphrey gave about study designs, we said that really the only type of study that you can prove cause and effect are, quote, experimental, potentially randomized studies where you, as the researcher, create the intervention and you assign the participants randomly or without much choice, shall we say, to one side or the other, not the doctor, but you, to one arm or the other. And so, yes, that is where are okay saying if you find out that group A that got the treatment did better than group B that didn't get the treatment, you can say in that study the treatment worked. The treatment causes the disease to go away. Nevertheless, even in non-experimental studies, we're driven still by this idea of causal inference because we have an underlying suspicion, a hypothesis that there is a cause and effect relationship. And we want to come as close as we can to proving it. But it's difficult to do that in an observational study, and I'll show you why in a minute. And but importantly, keep that in mind that when we talk about observational studies, still behind all of this is the idea when you're looking for associations, you're not just looking for associations to say, oh yeah, well, there we found that age is related to, death. Well, first of all, we know that, but it's also important to realize what associations do I care about? I care about ones that I can intervene on. I care about associations where if I knew A was the cause of B, I could actually do something about it. Okay, so when we all do these dissertations and we come up with risk factors for death, and you've seen this in 100 studies, we find age causes death. Well, it doesn't really help you as a physician to know that unless you're going to start making healthcare rationing decisions, which we sometimes have to do based on age. So it might tell us how we have to treat that person, but it's not going to really tell us that this person, that we can do anything about their age. On the other hand, if we look at the question of which is better, normal saline or Ringer's lactate for DKA, there, if we did an observational study, and in that observational study, we found that the patients who the doctor gave normal saline to, or the doctor gave Ringer's lactate, so different patients treated probably by different doctors who have different preferences for what fluid they use. If we found that one group, the group, say, that got Ringer's lactate, did a lot better outcomes, shorter acidosis, less time in the ICU, fewer deaths, whatever, we would say it looks like Ringer's lactate causes a faster improvement in DKA. We can't definitively say it because it's an observational study, and I'll explain to you why in a minute. But nevertheless, that's in our brain when we're doing these studies, looking at what factors in the patient's characteristics and in our treatment are affected with survival or death. It's always about that causal inference. Now, why can't we just come out and say that the patients that got Ringer's lactate did better, and therefore Ringer's lactate is a better treatment? We should be using it forever. And that gets back to the question that we said earlier, is that there can be, when we find an association, we can have the association may be cause and effect, effect to cause, or there's a third factor involved. And particularly in observational studies, there is often a third factor involved that actually is the cause. And if you don't measure that, then you will mistakenly think that you have found the cause and keep treating everybody with Ringer's lactate, when in fact it turns out that the people who use Ringer's lactate have more experience, and give it at a different rate. And remember to give insulin even when the glucose gets less than 250. And so there are other reasons that the person that Ringer's lactate is associated with less mortality, because there's some other factors that go along with using Ringer's lactate. I hope that makes sense. So, and that's what we call confounding. Um, so this is what they call a causal pathway. These diagrams, and you'll see a lot of these if you do any reading on uh, causal inference, or frankly on confounding. And I can't remember if you've covered confounding already, but it's the main reason why we cannot use observational studies to say something is a cause and effect. But I'm going to give you a caveat to that, because more and more scientists are finding ways to come pretty close to saying it's a cause and effect, just with new statistical techniques and other ways of doing things. But confounding is essentially this, that you have an exposure or you have a treatment and you have, say, a disease. So example would be, let's say, lung, smoking and lung cancer, right? Now, if I say smoking, okay, that's the exposure, and disease is lung cancer. But it's not really just smoking that's causing it. It's the tar and the nicotine that's the cause of cancer. It's not inhaling on a piece of paper. And so there is the confounder here essentially is that the tar and nicotine are in the cigarette, and tar and nicotine are what cause lung cancer. So it looks like we have this is the cause, but in fact, in reality, what we know is it's what's in that cigarette, and that's the confounder. Now, if you were to do a study on cigarette smokers and you didn't measure how much tar and nicotine is in the cigarettes they smoke, you might not recognize this as a relationship, and that maybe even though we may not be able to stop people from smoking cigarettes, perhaps if we lower the tar and nicotine, we could prevent some diseases. So the key here is that when you do an observational study, you need to think about what the potential confounders are, and you need to measure those as well. And then you need to see which one has the stronger relationship with the disease. A better example of this is that this is sort of the classic epidemiological example, is that you look at people who carry matches. Okay, so people who have matches in their pocket, okay, they're more likely to have lung cancer. Now, do matches cause lung cancer? No, right? We don't think so, right? But what's the relationship here? What's the confounder? People who use matches are smokers. This is so smoking becomes the issue here. And smokers, we know, get lung cancer. So that's why if you do a study looking at everybody who carries matches, you better also be checking whether they smoke. So very much when we collect data, we may have a cause and effect idea in our mind, but we have to think ahead of time before you collect the data as to what possible other things could be confounding the relationship that you think is cause and effect. And this is it's basically a hidden factor. If we look at this question of sepsis again, do patients with sepsis who are intubated have a better prognosis than those not intubated? And we do a prospective study and we collect information on age, on their clinical presentation, and their treatment. And we do a chi-square test and we compare the proportion of patients who were intubated who died with the proportion of patients who were not intubated and died. So we're looking at death rates in the group that were and weren't intubated. Now, you could argue this sounds like a randomized study, but it's not ethical for us to randomize people to intubation versus not intubation. We would never tell a physician, hold off on intubating that very, very sick person because they're a randomized study. You'd never get IRB approval for that. So by necessity, this kind of question would have to be answered with an observational study, meaning whatever happens in real life, that's what you'd have to live with and deal with. Okay. And so, as we talked about earlier, you find that patients who were intubated have a higher mortality. And you think, does this mean we shouldn't intubate sepsis patients? And it might mean that. It might mean, in fact, that intubation is harmful to sepsis patients. We think that actually may be true in DKA patients, but we're not sure. But that's also something clinically we haven't completely figured out because can't do a randomized study on that. Okay, so does this mean we should not be intubating sepsis patients? Now I can't see you all, but think in your mind, does this mean we should not be intubating sepsis patients? And the answer, of course, is no. Because here's the relationship we're seeing. We see that intubation is associated with death. Remember, observational study. They weren't randomized to an intubation or not. They just got intubated or not because a doctor thought they needed it. And we found that the people who were intubated were more likely to die. But there's confounding here. And that's that third factor. It's not that death causes intubation. It's not that intubation causes death. I think it's that there's a confounder here, which is that people who get intubated are sicker patients. So this also has to be measured. Now, so when you think about how am I going to do that when you're doing an observational study, you'd have to come up with some proxies for what's a sicker patient. And this is where we're what is the right thing to do. But if you have a disease, or a trauma score. If you can look at their vital signs, anything that you feel is a legitimate, and there are many things, marker of who is sicker. If you did that and then you looked at this group, what happened there? And then you would decide, was it that the intubation caused death, or were those patients a sicker group? The people who got intubated were a sicker group. And that's the relationship that we're seeing. Okay. That's the cause and effect relationship. Now, again, you're in an observational study, so you can't say it's a cause because it's observational, and maybe there are other confounders here as well. But that's why in observational studies where you can't randomize people to groups, you have to worry about confounders. Now, it may not make sense exactly why I'm saying, what about randomized studies? I mean, people are different who get put into randomized studies, right? If you randomize, 100 people with sepsis to take two different antibiotics, yes, some people will be sicker than others. Some will be male, some will be female, some will be older, some will be younger. But by definition, when you randomize people, you are likely, well, basically, it's a random sample, right? So people take their sickness, their comorbidities, their age. They get put in a group, but there's likely to be in the other group someone with very similar age, comorbidities, and so forth. And so they balance each other out. And even if they don't completely, we say that simply by the process of randomization, this allows us to still say cause and effect. If you think about it in real life, you don't know which patient you're treating right off the bat. You have a random group of patients. So randomization essentially mirrors more about what the individual doctor sees as patients come in. We don't know if this is the person that is going to be sicker, and so forth. So randomization allows that, basically saying the confounders are equal on both sides. Both groups have an equivalent number and types of confounders. And of course, the more people you have in the study, the more likely that is to be true in a randomized study. If you have 25 people, or 20, let's say even numbers, 30 people, that may not turn out to be true. But if you have hundreds of people, chances are that they're going to balance out. And if you've ever, you read randomized studies, you see that usually they do. It's I don't know. It's like flipping a coin. It kind of works out. So that's why randomized studies allow you to say, I'm not worrying about confounders, and I'm going to make this call that the difference between Group A and Group B is how they were treated. Um, so here you have the idea that I was talking about. That in a randomized study, each patients are assigned to each arm randomly, and the random assignment ensures that the confounders balance. And so all of these things essentially can be looked at afterwards, and you can see that the two groups have very similar age, level of illness, type of infection, and so forth. You don't actually do a statistical test to prove that because by definition, this is happening by random and the p-value should be less than 0.05 in terms of this not happening sorry, the p-value should be greater than 0.05 because of course it's happening by chance because you made it random, right? So, but you can look and see if there's anything that's really off balance. But for the most part, it isn't. And there's whole discussions about what you do if the one group turns out to be substantially older than another or whatever. But we're not going to go into that. But this is why we say randomized study. You can say cause and effect. In any other kind of study, you have to use the term association. You can't really, although you are implying a causal effect. So this is just more of what I was saying, regardless of that. Now, how do you mitigate this confounding? So I've already mentioned that ahead of time, you need to think about what are the potential confounders. This means not just sitting there and thinking, but reading a lot of literature of studies similar to yours or of the disease that's similar to the one you're studying and looking at what other confounders were checked in these other studies. Okay. And you want to, even though you don't think they're the cause, you still want to collect those so you can put them into some statistical software later to make sure that they're not the reason you're seeing the connection between A and B. And there are a couple of ways you can go about this statistically, and this is a whole nother lecture about how to do this. But one is let's say you let's say you had two groups and you were worried about age as a cause of death. Well, what you could do is you could first break the group up into two different age groups and analyze them separately and see what other factors other than age are affecting outcomes. So let's say I thought that my antibiotic choice was going to affect outcome, but I know that older patients are more likely to die regardless of what antibiotic I give them. So I collect a lot of data on hundreds of patients, let's say, and then I divide that group by age, and I take everyone who's over 60 and everyone who's younger than 60, and I analyze them separately for the effect of this antibiotic. And so the age now is taken care of. It's not a factor. Okay. Later, I'll have to tell you that yes, the death rate was higher in this group, but the death rate was not. The difference was not caused by age. That's caused stratification, and you can do that infinitely with other factors. It's a kind of tedious way to do it, and we don't do it very much anymore. But what we mostly often do is something called regression, where we basically control for all the other confounders in an equation. And then we see when we put all those confounders in this statistical equation, does the factor we think is still affecting factor A is still affecting B, we can say there seems to be a causal inference here that A, in fact, is causing B. The other way you can do it is you can match people. So you can say you have a group of 300 people, and you find, one group that is about 50 years old, a male, they have this many comorbidities in this group and so forth, and you match them, and they were the people that happened to get antibiotic A, and you match them with the people, same group of people, same age, same illness degree, same comorbidities, but they didn't get that treatment. Again, that was up to the physician. And so you basically create, as if you randomize two groups, one that got the treatment, one that didn't get the treatment, and that otherwise look very similar. And that's called matching. And that's difficult to do it correctly. It raises a lot of questions, but it is another way to do that. And then there's something similar that's called propensity scoring. The other way you can do this is when you do a study is you can prevent confounders from coming into your study at all by limiting your inclusion criteria. So let's say you were worried about age affecting the outcome. You might limit and only include in your study people under 60. Or, for example, in children, we often know that under fives just generally do worse. Maybe you leave out those over five in this study because what you really care about are the under fives. And then you can kind of treat them all similarly. You could also do a study, let's say you're doing a study on trauma, and you want to look at actually which one of our residents did, whether there's blunt cardiac injury, and you want to look at people who have abnormal ECGs. Well, you want to keep out of there people who've had prior heart attacks because that could be a confounder for an abnormal ECG. So you just don't allow that person into the study. But you have to be very careful with that because you don't want to exclude too many people, especially if you don't have a lot of time to recruit, because you won't get enough subjects. So you want to be you want to be limiting. You can also do that later, but you should say that you're probably going to do that later. In which case the IRB will say, well, if you're going to only include certain people later, don't enroll others because that's not ethical. So lots of different ways around this. The main thing is that you have to be aware of confounders. You have to be able to know your literature well enough to not miss things that other people already know. And really importantly, in a new study, in a study in a new setting, you should be thinking about other potential confounders that aren't in these other studies. An example, say at Mmbando, is how referral versus non-referral patients, or how long did it take someone to get from the time of the disease to getting to you? And if there's a long delay, that could explain a bad outcome. And now in my country, we don't really look at that because people have easy access to high level emergency departments almost everywhere. But in your situation, you might think, oh, that could be a cause of all why people are not doing so well. And maybe we can compare people who came to us on day one and people came to us on day four. And so that's a factor you, knowing your environment, can look at because, and that is something you can potentially change with some thinking about the healthcare system, training other hospitals, and so forth. Now, I told you you have to think about all the confounders. And you'd think, okay, if I do think of all the confounders, well, then can't I say cause and effect? And the answer is we really say no because they're always unknown confounders. That's why randomization, people they have unknown confounders we haven't even measured. Okay, we just don't know what they are, right? Genetics, right? We're now starting to see that genetics is confounding how people respond to medications. Well, we can't tell that from a study. So causal inference is always going to be hindered by unknown confounders that we don't know about, we haven't measured, and so forth. But again, in a new setting, you might be able to find some that haven't been looked at before. And that's the excitement of research, is saying, this is it. This is one of the problems we have. Okay, so finally, just want to say one other thing. You're doing a study and you look and you get this result, and you want to write in your discussion, that such and such was associated with such and such, and now you're coming up with some giant theory as to why this is happening. But sometimes in observational work, simply because you are sometimes looking at a lot of data and putting things together and trying to find associations, you're going to find what are called spurious associations. They come up as p less than 0.05, but they're not real, they're not important. And if you remember, what does p less than 0.05 means? It means that you have a 95% chance that you got this result not by accident, but there's a 5% chance you did get it by accident. So you have to be logical in your thinking and go, is this one of those that I got by chance? And particularly if you do a lot of tests, if you do 20 tests, 5% will be wrong because just the p-value says I'm allowing 5% uncertainty. So one of my tests of 20 may have the wrong answer. So you have to think about, does this make any sense? And so there also has to be what they call biologic plausibility. It's not always biologic, but it has to make sense. And don't start looking at associations that you find and go, oh, wow, I discovered, something causes something. And of course, there's absolutely no relationship, and it's simply something you accidentally found. There really needs to be some logical connection. And I'm just going to give you one last example of this. So a medical student comes to you and tells you have to stop screening for frailty in the ED. Now, frailty screening is becoming a big thing in a lot of EDs. I know I don't think you're doing it. My ED didn't do it for a long time. What it is, it's just there's a frailty score where you can see you measure certain things in an individual, and if they have a high frailty score, they're at higher risk of falls, at higher risk of death in the ED and in the hospital. And it can help you bring in resources like geriatric people and make sure they don't get confused in a day and night cycle and that kind of thing. But it also suggests that they may not do as well, and you may want to limit your resources. So frailty screening is now actually required in the UK in the EDs. So, but anyway, a student comes and he says, we looked at this and everybody, there were people who were screened, and the people who were screened for frailty had a higher risk of death. So we have to stop screening for frailty because obviously screening is causing them to die. Okay. And so you have to sit the resident down and go through this whole lecture and explain to them about causal inference and about confounding. And you figure out what's going on here. Why are people who are being screened for frailty more likely to die? Well, the answer is who gets screened for frailty? Older people are more likely to be screened for frailty, and older people are more likely to die in the hospital. So in this case, screening is not the cause. Age may be. Age is the confounder here. It's not A causes B. It's not B causes A. It's that there's a C, the confounder, that is causing the resulting in the death, but also is the age is also the reason that the person got screened in the first place. And that's the definition of a confounder. It has a relationship with both the A and with both the exposure and the disease. And so you have to think about, do I have a confounder here when something that biologically is not plausible comes into your study? And so there you can see that this would be the example of this one, that the person screened, they died. No, it's because people who get screened are older. Okay. And people who are older are more likely to die. And so that's the relationship you have to talk to this poor student about and spend an hour discussing confounding in a busy emergency department. So, in summary, we base our research on the idea of causal inference, that is, that one or more variables affect the outcome variable. But this causal relationship may be due to a hidden additional variable, one or more, what we call a confounder. In randomized studies, we essentially equalize confounders in the two or more groups simply by randomizing. In observational studies, we have to mitigate confounding a different way. And as I mentioned, this can be done by limiting the inclusion criteria, matching, or measuring potential confounders during the data collection, and then accounting for them statistically when you do your analysis. And remember that any association that you come up with should have a biologic plausibility. And that is cause inference. So I will stop there. And I know that's very heady, but hopefully it gives you some idea of what we're doing when we do research. I will take any questions, Swali.
Thank you so much, Bibi. Asante sana. So, any
Karibu.
question, please? The floor is yours. So you can just unmute and speak.
If nothing else, I mean, I know we'll wait a second, but while we're waiting to see if anyone comes up with any questions, can you all for 1 minute just take yourselves off, put your video on so I can see you all and say hi? Who's going to be the first brave person to show me their face?
But please, Be the
Thank
first one.
you. Hytham, thank you, Dr.
Item,
Hytham.
yes.
All these camera shy people. KP, thank you. Well, I will
MP has to
quote.
buy a phone.
Who's got that finger, that horrible I have to say, Dr. Henry, I have to say you look like a rapper doctor in your picture. So I'm wondering, thank you all. This is great. Dr. Joyce, Dr. Suode, lovely. Thank you so much. At least I know who I'm talking to. I can't believe there's so many of you.
I'm scared you have some robots here.
I can't wait to see your graduation dinner. Dr. Herbert, thank you. If I didn't call your name, it's not that I didn't see you, but it's coming. You're going on and off quickly. Okay. Any questions?